Hello, everyone, and welcome to the Athletic Shoulder podcast. My name's Ben Ashworth, and really delighted today to have Annelies Maenhout on the show. Annelies, welcome.
Thank you, Ben. I'm delighted to be here. Thank you for the invitation. And your pronunciation of my surname was perfect.
I'm delighted. It's really important. So, Annelies, we've had a bit of a discussion about each other's backgrounds off air. We've probably read about each other, but not met really. So, for the listeners, could you just give a little bit of a background as to your kind of journey and how it all started and what you're doing at the moment?
Yeah, it started, I think, almost 17 years ago now. I graduated in 2008 as a physical therapist in Ghent at the university. And by my graduation, I really loved the education. I loved everything about physical therapy and I enjoyed the program. But during my internships, I didn't see myself working in those practices that I had been in. I didn't have the chance to be with a good physical therapist. And then I had the opportunity with UNCOS to start a PhD. So I thought I just start there and I will see. And that's how I came back into practice, because I started liking to treat patients again and started to get interested in shoulder rehabilitation. And that's how it started for me. So I'm very grateful that I got the opportunity from Anne to start in research. And at this time, I combine research part-time at the university in Ghent, in Belgium. And I work in practice part-time, where I treat patients with shoulder problems. So part of those patients are athletes, but part are not athletes also. So all kind of complex shoulder problems.
That's great. And Anne, for the listeners, is a very well-respected researcher in Belgium. And certainly when I came across your work to start with, it was around some of the EMG stuff that you'd done there. Could you just kind of go into a little bit of kind of almost the journey? If we start there, we can talk about some of the other work you've done and then how it applies.
Yeah. In the last year of my education, I did my master thesis with Anne as my promoter. And that was a project on healthy subjects, which performed the push-up plus exercises. And we did the EMG recording of the scapular muscles. And we experimented with the kinetic chain, like extending one leg, extending the other leg. And that was my first study there. So that's how I got into EMG research. And I still use the findings from this study because it really learned me. And I think it's really interesting when you work in practice to see a patient moving while simultaneously being able to watch the effect on your EMG of your muscles. So you can really see the real life impact of how you move on your muscle activity. And what I specifically still use from that study is that how leg extension affects your scapular muscle activity. So like when you want to have a higher activity of your serratus anterior, I always try to work in the anterior chain and use the heterolateral hip flexion to increase the anterior chain activation. And when you want to activate the muscles in the back, like the lower trapezius, middle trapezius, I extend the heterolateral leg to increase the activity of the posterior extension chain. So that was my first study on EMG, which was really a successful study because we got it published in a good journal.
It was a really successful study and something I still use actually, especially in early rehab, when maybe you're in that kind of closed chain bilateral stance, but you're using leg extension. You build. I use that to build circuits, and I still have in my mind your reference from the early work there. But yeah, so I suppose then with the EMG stuff that you used then, and you're still using it now. I'm doing some EMG stuff as part of my PhD. For people working in practice now, I mean, do you use surface EMG, in practice for biofeedback? Is that what you're currently doing?
No, I've been there. I've had different episodes of trying new things. I've been there. I've used it. I bought a little device which had a wireless feedback EMG, but I changed a lot in my practice now. So in that time, I really was into internal focus. So really trying to explain my patients how they should recruit their muscles, and I showed them the real-time biofeedback. But I changed a lot after reading a publication from Kevin McQuaid on scapular stability. I don't know if you know the publication, but it's scapular stability. Are we on the right track? And that really got me thinking. We always learned to increase muscle activity around the scapula and teach the patient how to recruit the muscles, but that's not how our brain works. If we increase the muscle activity around it, we've tried to fix the scapula, and the scapula needs to move around. So I got rid of the biofeedback and I changed a lot in my practice. And now at this time, I really try to avoid to explain patients how to recruit their muscles. We should not explain. That's not how the body is meant to work. And especially from another study that we did on the plyometric exercises, that was also an interesting study for me to learn how fast exercises, changing direction, how that increases your muscle activity much more compared to internally focusing on actively recruiting muscles around your scapula. So you just have to challenge the scapula in the right way to increase the muscle activity there. And like the serratus anterior, instead of using protraction exercises, you should just challenge the scapula by increasing the co-contraction by plyometric exercises, for example. That's one example. And then you don't need to explain your patient what they should recruit or should not recruit around their scapula, but you should just find the right exercises. And like the serratus anterior, it was very interesting to see if you train in the higher elevation and you use the plyometric exercises in this position, you have a very high activity of your serratus anterior, much higher than when you do the protraction, the push-up plus exercise, for example.
Yeah, that really resonates with me because as we spoke beforehand, I'm currently looking at no, the listeners won't be surprised. I'm looking into EMG of the ASH test, but the muscle activity in the scapular stabilizers in those longer lever positions, it's about the demand on the serratus muscle. It's not the serratus doesn't know what exercise you're doing. It just knows it's been challenged in some way. And I think that's great. It means that we stop focusing on push-up pluses and we start looking at with your work and the McQuaid study, we start to look at just challenging the scapula, which I think is a really great learning point from this conversation.
Yeah.
Before we go into some of the internal external focus of control, because I think that's and that kind of idea of the brain involvement, there was some other stuff around just maybe some clinical trials with glenohumeral internal rotation deficit, because that's something I know I've changed my practice on over time as well. Could you just talk a little bit about how your approach has changed over time?
Yeah, on the GERD, on the
Yeah.
stiffness in the shoulder. When I studied physiotherapy, we learned about GERD being the 20 degrees difference between sides and using the sleeper stretch. And I did a study in my PhD where we had a group of volleyball players with GERD. We selected them based on 20 degrees deficits on the dominant side. And we had them stretch for 6 weeks with the sleeper stretch, just a static passive sleeper stretch. And we measured the mobility, of course, to see the impact of the stretching exercise, but also the supracranial space. And it was really surprising to see that the supracranial space was smaller when before they started stretching, when they had the stiffer shoulder, and after stretching, their mobility improved and their supracranial space also improved. So I think it is still can still be relevant, but we need to. It changed for me that I need to select the right patient to try to increase the range of motion, and I changed how I want to increase the range of motion. So I don't try to improve the range of motion in all my patients anymore. Where I see 20 degrees deficit, I think it should fit into the clinical reasoning of the pattern of shoulder pain, that it is relevant in this patient, because in all subjects, not only athletes, you see a deficit of internal rotation. So I think it's normal that your dominant side is much stiffer, especially when you load it a lot when you're an athlete. But you should you should have a hypothesis that the deficit has something to do with the complaints of your patient. And the way we want to improve the range of motion, I don't do passive stretching anymore. I think it's much more relevant to use high load training in the end range internal rotation and try to have a variation of exercises, not only the position of the sleeper stretch, but also the deceleration of your throwing motion, depending on which sport you can adapt your exercise. And I think it's really relevant to improve the strength throughout the internal rotation range, because that might be the reason why they got stiff in the first place, because they don't have the strength to go there.
Yeah, that again, I think that's great. Basically, that posterior shoulder weakness, maybe deficit, creating additional stiffness through overload from those kind of deceleration movements, and actually by increasing strength, you reduce stiffness. The old classic of a sort of a tight muscle is a weak muscle, effectively. You sort of mentioned there sort of choice of patient, choice of athlete, and I just want to dig in a little bit. I'm interested in this. Um, what would you say then would make you change your decision making about whether you want increased internal rotation range? If we're looking at someone who's got 23 deficit back to the old GERD standards, why would you choose not to stretch versus stretch? Are there some other factors and considerations that you have?
It depends. For me, it depends on the sport. If you have a unilateral sport, I think it's normal that you have 20 degrees difference in your range of motion. And maybe it's not good to put the 20 degrees, but you can have some stiffness in that shoulder, for example, in tennis players or unilateral overhead athletes throwing a lot. For example, in a swimmer, you want a more symmetrical profile there. So, and if that has something to do with the complaints of your patient, then I think it might be relevant. Yeah, I understand your question. It's difficult to answer. It depends a lot on the patient you have in front of you. And it's the combination, the clinical reasoning. For example, a combination of a high laxity of the shoulder anteriorly, and they tend to put their humeral head a lot in front, and there's a combination with that stiff posterior shoulder, then that might be a good candidate for me to improve the strength throughout range, but without passive stretching.
Yeah, that makes sense. That was kind of what I was thinking about, and certainly the hypomobile versus the hypermobile shoulder, being cautious of the translation and what we might see when we wind up internal rotation and they have no more, they will use shear force to try and achieve more motion. So that consideration, I think, is really important. Otherwise, like you say, you interpret the 20 degrees rule from the literature, and then you apply it to every client or every patient. It doesn't translate. So I think that's absolutely right. Is the individual patient, sport, and situation
Yeah.
big difference to the exercise prescription? Yeah.
And try if you can change the symptoms. Sometimes you can really change the symptoms very fast by performing an eccentric exercise, an internal rotation, and you have a comparable sign, like they feel the pain when they perform this movement, and you give them the exercise, and afterwards you check if that changes immediately something to their pain. That's also for me a good argument to apply it to that patient. But if they don't have an effect after performing this exercise for 2 weeks, I don't think you should continue.
That someone said to me the other day, I applied a technique in clinic in the room. I rechecked the range of motion afterwards, and they said so many people don't do that. You know, that test retest. I think even waiting 2 weeks, but even just in front of you, have you made change that you can see and the patient can see? I think is so important. It's almost a
Yeah,
little. It's research, right? It's like
yeah.
mini experiments.
And it gives your patient a good argument and motivation to do the exercise, because
Yeah.
you can immediately prove that it will be relevant for this patient and it will help to be able to sport without pain. And that's what they want.
Yeah, I totally agree with that. And 20 degrees, I think, has been a real line in the sand for people, which confuses people around this particular loss of internal rotation. I mean, I remember having a judo athlete who, if she was below 19 degrees, we knew that she'd have shoulder pain. And then a tennis player who, if she's below 25, we know that it's it's very variable depending on the individual, and you start to learn within the individual that there's differences, complete differences in
Yeah.
yeah,
And it's balancing, and it's often when it's sports related, they will decrease after each training and after each game. So they need to learn how to self-manage
yeah,
this mobility, because otherwise their pain will come back when they stop doing the exercise. So if they understand what they are doing, and they can really recheck their own symptoms after doing this exercise, they will tend to keep performing this exercise in the future, even when you stop guiding them.
yeah. Also, it takes a bit of workload off you if they know how to manage their own range of motion, right? So you're not doing
I
hand,
think it's really the
yeah,
self-management. I think it's really important.
especially when you've got 28 athletes that you're working with in a group. So yeah,
Yeah, and it's our mission to improve the understanding of the patient, of their body, and what is happening. And the better they can understand, and they can predict, if I do this, I feel that, and if I do this, it helps me, the more likely they are that they will become pain-free.
you mentioned a little bit about the GERD stuff and actually talked about some eccentric work. Do you use quite a lot of eccentric work in your practice? How do you sort of apply that with the athletes you have with?
Yeah. Depends on what the goal is. When I started my study on eccentric training, it was in a time where eccentric training was considered like a magical exercise because it was eccentric. So I changed my ideas about that a lot. I think you should only use eccentric training and unloading the concentric phase when you want a higher load, to apply a higher load, or for example in case of a tendon pain, when you feel that you resist a movement and your patient feels a pain, like for example the external rotation or your scaption, and it's painful and you cannot change it by doing something else biomechanically, and you interpret it like it's the tendon that feels painful and is sensitive, then you can use an eccentric exercise, because you can load it higher, and we know that yeah, you want to trigger the tendon to become more active and to start repairing. And that's an argument for me to use eccentric training, because I can use a higher load. But then you have to load it higher. And I often see in clinic patients performing an eccentric exercise with a weight that they could also just perform concentric, eccentric in two phases. And another argument for me is when you need the eccentric movement in your sports. So when you need to decelerate something, like you decelerate your cocking phase, then eccentric training is relevant, because you want to be strong in this deceleration, or your deceleration and the follow through. So those are for me the two circumstances in which, for me, eccentric training is relevant.
Yes. We talk about like a super maximal overload, and I think that's a really key point is if we're trying to drive muscle tendon adaptations and we want a stimulus that's sufficient to drive those, the highest loads are super maximally centric loads. But as you say, not just something that you can then control down and then concentrically load up. It has to be something that you are really fighting and then almost have to take back up to the start position yourself. So that's the difference, I think, and sometimes it's mistaken when we apply eccentric training. It's not that we just want to move through an eccentric phase. It's the level of the intensity of the exercise. Yeah.
Yeah, I agree. And also, the eccentric training, it was the first time that in practice it was suddenly allowed for patients to feel pain. And I think that also changed a lot. I still use the pain monitoring model that Karen Silbernagel also used a lot in her studies. So it's just about giving your patients some rules which they can apply again for this self-management of their training. So they feel that this movement is painful, and they should not be afraid when an exercise is painful, when they apply some rules. And again, you can adapt the rules to the patient and to which sports and which phase of your rehab you are in. But if your patient has clear rules on what is allowed, which pain is allowed on a visual analog scale, how much can they score, and how long can it persist, or when should it be gone, then it again gives them some trust to perform a painful movement and not avoid everything that doesn't feel okay in their shoulder. I think that also changes a lot in a lot of patients, but you have different types of patients, of course. Some patients don't avoid it, and they can also benefit from having some rules to understand if they overload every time again, that will not result in a pain-free shoulder in a few months.
Yeah. There's some subtleties in and around how you manage for example, the throwing shoulder in season. Maybe we take a different view on a pain scale, or maybe on the exercise we might use. And certainly the eccentric, super maximal eccentrics are hard work and have a cost to them. So in rehab and not necessarily in season, they can be really useful. And one thing I think about there is like, again, rather than just the sport, is maybe just the type of tendon issue, whether it's reactive, more chronic. We can probably target the chronic one a little bit more aggressively, whereas the reactive one, we're going to back off in terms of the visual. Yeah, I think that's really useful. I think also what you're talking about there, and it'll kind of take us nicely into the brain stuff, is remapping someone's ability to understand pain and how that influences movement. But we talked right at the start about the change from internal to external focus and the way that the brain. I think that's led you down another research path, which we can probably go into. I think that would be really interesting for me as well as the listeners. So how, where are you at the moment, and kind of, can you just talk through that internal to
Yeah.
external focus?
Yeah. But first of all, I got really interested in external focus, and I will talk about this guy later again. But I gave a course in the Netherlands. It's almost 10 years ago now, I think. And there was one annoying Dutch guy always asking questions. And at that time, I was really into, I'm a dancer. So I like to explain how you should move and what you should feel during an exercise. And he really challenged me by asking the right questions. And after that, I changed my view until now. I really try to avoid explaining things. So I talk much less in practice now than I did before. And we designed a study because we were interested in how it would change your EMG activity again in your scapular muscles. So we started from the basic exercise, like you explicitly explain to your patient to perform a posterior tilt of the scapula while doing a flexion exercise. We had another exercise where we didn't explain anything, but we gave them a laser pointer and we asked them to follow a line. And the goal was, because they had to improve their accuracy, that they might also increase their activity around their scapula. And then the third exercise was the same, but we put them on an unstable base. So they had to control the unstable base, had to keep their pointer on the line. And we compared the EMG activity during those three exercises. And it was really interesting for me to see the results. And it helped me to understand what I was doing wrong in practice. Because when you explicitly ask a patient to perform this posterior tilt, you like pinch the scapula to the back, you increase the activity of the middle and the lower trap, but its activity stays the same throughout your entire movement. While when you don't explain anything and you just give them a laser pointer, your activity goes much higher, but it again decreases afterwards. So when you explicitly ask a patient to recruit a muscle, then you like fix it, and you also won't allow the muscle to increase its activation throughout the range of motion. And in a lot of other muscles around the shoulder, you saw that when you don't give an explanation on how the movement should be performed, but you just want an accuracy of the movement, then the body reduces muscle activity in a lot of muscles around the shoulder. So maybe we looked at it the wrong way for a long time, because we were always interested in finding exercises that increase muscle activity, but actually our body is designed to decrease muscle activity to be efficient, because when we don't use a lot of muscle activity, but we have the same output, then it's just a more efficient movement and more effective movement. So that changed a lot for me.
Yes, that makes a lot of sense to me, and it sort of reminds me of the athletes that we see who've been told to set their scapula, right, and that still happens even in 2025. You know, put your scapula in your back pocket, set your scapula. That 100% creates issues in rigidity, uh, the inability to let go, to get overhead into those overhead positions. It's just, yeah, it's mind blowing for the patient. It's also mind blowing for us to see that still happens. But then you've put some science behind that, which is fantastic.
But you cannot you cannot be angry at the physiotherapist that still applied, because it was how we learned it always. And it's not easy to elicit it without explaining it. You really have to learn to work with implicit motor learning. And that's what I learned a lot from this Dutch guy. It's Wieger Heijink. It's a physiotherapist working in practice in Zeewolde in the Netherlands. And he's really like a magician with shoulder exercises. He can look at a shoulder, he feels what the shoulder needs, and he can have the patient play during exercises, and he elicits the right movement that you want the scapula to perform, but without explaining anything. And that's it takes some time to learn how to apply that. So it's not that easy without explaining what you want to get the right results. You need to have some inspiration from exercises, and I learned a lot from him. He uses a lot of interesting principles to elicit the movement of the scapula, and together with him, that brings me to my next study. We developed an implicit motor learning program for patients with chronic shoulder pain, but I also apply it in patients, in athletes with shoulder pain. And we use some principles there. Like, one principle is the external focus, so we don't explain how the patient should move. We use analogies, we use comparisons on how the patient should move. Like, for example, they had one exercise in which they had to stand in an unstable way, so it depended on the level of the patient, unipedal stance or the tandem stance, to challenge their balance. And then from there, they had to touch things lying on the floor in different directions. And he uses the analogy of the legs being in a cast, and then you cut the cast so they are allowed to move again. So you don't explain how you want the patient to perform the movement, but you just use comparisons to give an image to the patient. And another principle that we used was we wanted to destabilize the body. So it's like you give a puzzle of a movement problem to the body, and the body has to find the right solution to control everything, to succeed in the task to touch the objects lying on the ground. And you can see how patients, if they are too protective in their shoulder, they don't succeed. So they have to let go if they want to succeed in the task of reaching towards the objects on the ground. And the last principle that we put in was that the targets really had to be out of reach. They were almost not able to touch them. So they were challenged to free their scapula and to free their thoracic spine, and to try to integrate everything into the movement. So it was really interesting to design the program with him and to test it in patients with chronic shoulder pain. They had very nice results. And it was much more fun to perform the exercise like that, instead of the analytical exercises in which they perform these exercises with TheraBands and so on.
I'm interested there how, and I totally sort of resonate with some of those external drivers there. I'm interested, how does that apply in practice? Because you're not only a researcher but also a clinician. Let's say someone walks in to see you today. What would make you go down that sort of path with that patient? Are there some indicators that you would see that you think, right, that's the ideal person that would work well with this?
Yeah, there are different types and different circumstances. I can give an example of a swimmer that I saw, and it's a pattern that I saw multiple times. There's a swimmer, and you perform your active clinical examination, and you see that for a swimmer, they cannot reach full elevation. So they have a restricted mobility, although they have hyperlaxity in their shoulder, but they don't use it. So they restricted their range of motion, and to perform all those cycles of their swimming motion, that it's necessary. They have to be able to go in this full elevation, and that is a good patient for me to apply the principles and to give them exercises in an overhead position and have them reach in different directions. So they have to let go in their scapula, and you want an upward rotation in the scapula. You want the thoracic spine to move. So you have to challenge them in this position to improve the range of motion. And that's also something you can compare immediately after performing some exercises, if they changed in this freedom of, their increased degrees of freedom in their shoulder. You understand what I mean?
Yeah, I totally understand. I think that's then, again, remodulating the tone in muscles based on allowing them to let go. Sometimes we sort of assess people and we don't give them a chance to change, right? We say they lack mobility. We haven't tried anything. We haven't
Yeah.
done release work or we haven't done any retraining work. So
Yeah.
yeah, I think that's absolutely
Yeah.
right. Yeah,
And
that cute change.
And earlier, I thought I had to release that shoulder
Yeah.
to improve the mobility, but there's a reason why they don't use it,
Ah,
because they actually have a very high lax shoulder. So it's possible to do it, but they restrict it and they increase their muscle tone for a reason. So it's like you relearn the body to explore all the possibilities. It's like they forgot that it's possible to use all those components of thoracic spine mobility and scapular mobility and all these components to integrate it into their movement patterns. So it's like playing and having like children playing and discovering all these possibilities to move, and they have a goal they want to reach. So it's like you apply that in practice. And another example is athletes with instability, especially the non-traumatic instability. It works very well to use that implicit motor learning. They are in a pattern which is not a good pattern to keep the stability in the glenohumeral joint. And if we want to relearn those patterns, it doesn't help me to learn them explicitly which muscles they have to recruit, but it helps me to use these principles of implicit motor learning and find exercises that need that co-contraction.
that makes a lot of sense. And you'll kind of test, retest, because I think that's important to almost ground this as a, you know, a mini experiment. We're exploring how do we change their range of motion, or have you done anything around how that changes force output, for example? Not just range of motion, but have you seen that make changes on someone's strength or power, or you know, have you done any work around that?
No, that's a good idea. No, no, because the goal when I use these exercises, my goal is not to make them stronger. My goal is to relearn the brain all the possibilities and to increase their stability throughout range. But it's really possible that that also affects the strength you have.
I think we've got a nice collaboration for us. Once I finish my PhD, then
Yeah.
I've said that too many times on this podcast now. I'm in the final phases, so that's good. But going back to that point, I think in the same way that it can affect range of motion change acutely, if you've already got the strength, but you're just not able to access it, potentially by changing how you're mapping, I think again that might unlock, you know, higher force production output as well. Would be a real great thing to sell to the athlete. Like we've done these exercises, it's transferred into especially for an athlete, something that's improving my strength or power. I think that's really valuable. So
Yeah, yeah, yeah. For example, when they don't have a good co-contraction before they perform the output of their strength, when you test the external internal rotation range of motion, you can see sometimes nothing is happening here, and they just want to push, but they are shearing their glenohumeral joint. When you do exercises to improve the co-contraction around the glenohumeral joint, I think it could really help them to deliver a higher output of strength during your test. Yeah.
and then if you think about specifically around that, let's say your subscap wasn't contributing, you know, because it's inhibited in some way, then your internal rotators are trying to do the work of the subscap, and that will then restrict your external rotation range, you know, and overhead. So I think there's a huge amount of potential around. this kind of work that influences
Yeah,
that, just traditional stretching, soft tissue release, you know. I think
yeah, I agree.
we see that a lot in thoracic spines, don't we? Is like, well, if you're restricted in rotation, we have to manipulate, mobilize, stretch. But actually, again, with that area of the body, we know that if we can start to improve recruitment and almost down regulate the tone in certain muscle groups, we can see big improvement. So
Mm,
it's it's often a blind spot, the shoulder. We forget what we
yeah,
do in other areas
yeah,
of the body. Yeah,
yeah. It's asking ourselves why
yeah.
are they not using this range of motion, and it became stiff because they didn't use it.
Yeah.
So it can help to relearn how to use it and to rediscover that possibility.
We had a sort of pre conversation before this, and it was one of the things I was really excited to talk to you about because it's right up my street. Was the hole in the literature on reaction time in overhead athletics, and a study you're performing this year. Now, if it's what I'm trying to do at the moment, then well, you're going to beat me to it. So I'm really interested. What are you up to in that space?
Yeah, it for me it was striking that we do it in practice to train our athletes on reaction time because we know it's relevant and it's very important in a lot of sports to have a fast decision making and fast reaction time. And we suppose that when an athlete had shoulder pain for a long time, that there's a problem with that reaction time. But actually, there's no literature almost showing that there's a problem with this reaction time. So that was what we were interested in. And we could also not find very specific functional tests of reaction time. The best that we came across was from Kevin Wilk, his publication with the blaze spots, the tests that he created. I really liked them. And we designed another test because we wanted to make a comparison between the gold standard tests of reaction time, and that's like the plate tapping test. That's a measure of reaction time, and the ruler drop test. So you have a ruler and you drop it, and you want the patient to take it, to grasp it. So that's the gold standard tests that are used and that we have a lot of data on. But it's not very shoulder specific. So we designed another test. It's like a reaction wall with blaze spots. It's based on the study of on the publication of Kevin Wilk, but not in a closed chain. We wanted to have an open chain test. So they have 9 blaze spots, and the lights go in a randomized order, and they have to touch with one hand as many lights as possible in 1 minute. And then we had the same test in VR. So it's a Redzel player reaction wall. I don't know if you're familiar with the application. They have a reaction wall with 9 lights. So it's the same setup as the real live test that we performed. And we had athletes, healthy athletes and athletes with shoulder pain. We tested them, but we don't have the results yet. And we are interested, first of all, in the correlation. If you are fast in these golden standard tests, like a ruler drop test, are you also fast in the blaze spot reaction test? And are you also fast in the VR environment? And then we want to find out in athletes with shoulder pain if there's a deficit and which test is the best to detect this deficit. So I will keep you posted.
Yeah, we'll keep an eye out for that. That's interesting. One of the questions that I suppose, I get to see a lot of practice in different parts of the world. I've definitely seen blaze pods being used a lot more in shoulder rehab since Kevin Wilkes' study.
Yeah.
I suppose for me, it's like, what are the indications again for that kind of retraining? When do you put that into their training in terms of, let's say, return to play after injury? When does that come for you?
Oh, in terms of timing or in terms of for which patient is it relevant?
I think two things. I think both of those things, like the timing. When do you start your reaction type training? Yeah, that's question one is easy then. When do you start that kind of reaction time training? Let's say after a shoulder surgery, for example, would be like an instability, an anterior instability. When would you start that shoulder retraining reaction time stuff?
Well, it's difficult to tell in terms of exact timing because there's a lot of individual differences in timing, and it's gradually building up. When you have you need a full range of motion before you start with a reaction timing, because if you still have a restriction, then that might affect the timing, of course. And it depends on which exercises you want to do, but I really think it's important to incorporate fast movements and to relearn the muscles in the shoulder to very fast build up their strength, and that is where reaction time exercises are really helpful, I think. But it comes in the right order. So you are in your strength training and you are integrating exercises with increasing strengths like diagonals, and then you can start with your reaction time
Yeah,
exercise.
that's what I thought, but I was interested to get your opinion. I think that's really clear then, I think it's important to state these things because otherwise someone looks at some blaze pod research and goes, right, well, they can't apply high force at the moment, so we're going to do some blaze pod training. But you know, moving really quickly and rapidly, even in unstable shoulders in early stages, isn't always going to have a positive outcome. That's right time, right
Yeah,
place, the individual. Just
yeah,
take it
and
through the
in
progression.
small steps. Yeah,
Yeah,
in small steps, and it's not useful to do these exercises when you're still in pain. Your exercise that you've chosen should be pain-free because pain influences your reaction time. It's useless, I think, to do it with pain
yeah,
because your brain will not want to do that.
yeah. I think those are really clear outcomes. Um, and in term, because a lot of that will be quite high speed but low force. And obviously the demands of sport are high speed, high force, rates of force. Have you explored anything around that area as well with regard to athletes and return to play? Is there something that you're looking at in that space?
In research, no. In practice, yeah, I agree that it's really important not only to stay low load in your reaction exercises, in your fast exercise, especially in instability, patients with instability. You have to mimic the loads that they need during their sports, but then it depends on which sports. If it's a golf player, it will be different than in a handball player or basketball player. So you try to analyze which movements my patient has to do during that sports and what will be challenging. You can discuss with your patient what they are still afraid of and select those sports movements and yeah, turn them into exercises of different components to gradually build up towards that requirements of the sports.
Yeah, and working with the technical coaches as well. I suppose there's that transition, isn't there, from prescribing an exercise that looks like the sport and actually doing the sport itself, which probably is better than some of the exercises we prescribe. Um, really enjoying the conversation. Appreciate you've got other things to do as well, but just in terms of the kind of future for you in terms of shoulder research, where do you feel that's going? Where would you like that? Where would you like that to go?
Yeah. Some years ago, I came across a publication on muscle synergies. And that was the first time when that I started looking differently at all the EMG research that we did because we really, and that was always my frustration in research, that we have to simplify it so much that it doesn't reflect the reality anymore. And that is shown in all the different results of studies. You see higher activity in patients, you see lower activity, you see more upward rotation, less upward rotation, because the research is simplifying the reality. When you're in the lab with all those different monitoring on your shoulder, and you have these researchers watching you, and you have to perform in 5 seconds an elevation that does not reflect how we move in reality. And also in the analysis of our EMG research, we had throughout the exercise, the activity of your muscle, and then we take the middle 3 seconds, then we take the average. So we create average patients which do not exist, because you have patients with higher and lower, and so you neglect the variability in your muscle recruitment and your motor behavior. And I was really searching for a way to capture more the individual variability and the coherence of how muscles are working together when we perform movements. And muscle synergies might provide a good answer to that. I don't know if you're familiar with muscle synergies, or I explain it for the listeners, but it's you need a lot of muscles to detect in your research. So, for example, you start at the trunk with the erector spinae, you have the latissimus dorsi, the pectoralis major, and all the way up to the lower arm muscles. And then you perform an analysis on your data set. So, for example, throughout a reaching movement, you try to search for coherence between muscles that work together, always in the same with the same strategy, and you try to find a way to predict your data set. That's what you do. And like for a reaching movement, they found in healthy subjects, but it has not been used almost in patients with shoulder pain, that you only use 3 to 4 muscle synergies to perform a reaching movement. So you have 3 sets of different muscles that work together in a specific timing with a specific weight of each muscle. And those 3 synergies, they are always the same that we use, but we can adapt them a little bit in terms of the demands of the task. So that makes it more simple for our brain to select those 3 synergies than if we would have to select each muscle every time we do a movement. It would be very fatiguing for the brain. And I think this analysis really captures the complexity of how we shape our movement patterns. So I'm really interested, for example, in patients with shoulder instability. We wrote a project on examining their muscle synergies during reaching movements without apprehension, and reaching movements with more apprehension, and also with fast reaching movements, and to see the differences between healthy subjects without instability and patients with instability. So we really think we will see changes there, and in this way we hope to capture more the individual variability and the inter-individual variability, and to better understand what they need in terms of exercises to retrain these motor patterns. So that's one area for the future that really interests me. I think in shoulder patients, there's a lot of work to do. Also, like scapular dyskinesis, we conclude it's not relevant because research could not find more scapular dyskinesis in patients with shoulder pain. But I think when we would look at muscle synergies, that might really help us to detect the variability in scapular movements, and which patients get pain and which patients do not get pain. So I think it's a really interesting topic.
It is a fascinating topic, and a rabbit hole, I think, has been described as well. It's difficult to prove one way or the other with conflicting research and evidence, isn't it? Based on the way that EMG is currently explained. But I think the muscle synergies idea is something that comes from some of the functional anatomy, like so some of the research and reference, like the Hick, Ackland, Pandy type muscle architectural work. Have you got any muscle synergy papers that you go to as your recommended papers that you would say for the listeners are worth reading?
It's I found two studies which of I will send them to you
Yeah,
afterwards, and
we could link them in there.
they
We could link them in the
they
research.
looked in swimmers, but it's still not that many patients, and I don't know, it needs to be improved, I think, but it's in swimmers with shoulder pain. And they looked at different strokes and they compared them with swimmers without shoulder pain. And for example, they saw in different phases of your breaststroke that there are muscles that are more active in that synergy or less active in that synergy, and they really give a good interpretation that is understandable for the clinician. So I will send you those studies. But for the rest, there is only literature in healthy subjects on reaching movements and on isometric external rotation movements. So we are only in the phase now of trying to understand what are the muscle synergies that we use, how many do we use, and how do we adapt them to different tasks like reaching or isometric tasks. So it's really interesting, but it's difficult literature. And not all studies have a good clinical interpretation that is relevant for the clinician to understand and to imagine how that would be in practice then. But the two on the swimmers, I think, might be interesting for the clinicians.
Well, interesting for the clinicians, interesting for me as well. Again, like with the work that I'm doing as well, looking at the synergies in testing in long lever positions, right? There's if you use AI, you can really easily capture a huge data set and you can start to see and ask questions about the data. So we start to see clear muscle synergies across multiple individuals. So not just, one individual. We're looking at patterns. We're looking at, for example, maybe we might see contralateral external oblique and upper trapezius being a synergy in a particular movement pattern, probably based on almost again the functional anatomy and the alignment of those muscles and how you'd expect them to work. But I think that's fascinating. I'm looking forward to hearing a bit more about that, and maybe we end up working together in the future.
Would be happy to.
Fantastic. Look, thank you so much for your time. I've really enjoyed this conversation. I think it's been brilliant. The application of the science, the research, and your journey, and how that's applying to what you do every day is just great for me. Thank you so much. Where do people follow your work, or maybe even reach out and get in touch with you?
I'm not a very active social media like you might have seen. On LinkedIn, you can contact me.
As
So
I
yeah.
did. Yeah. That's perfect. Well, we'll link that up.
Yeah.
But once again, thank you so much for coming on the show. We really appreciate it, and I'm sure the listeners will have enjoyed this conversation as well. Thank you again for your time.
Thank you so much for having me. It was always interesting to discuss shoulder pain in athletes. And thank you for the conversation. And anyone that is happy to work together, or you can contact me if you're interested.